Any optimism for any new agents in small cell? We're going to see some data on lurbinectin and...
Yeah, I do. And the lurbinectidine data is pretty interesting. This is, for those who are not familiar, agent that's derived from the C-squirt. Interesting fact, it's in low concentrations in the C-squirt. It takes about a ton of C-squirts to make a gram of trabectidine, which is a related compound. So clearly, to be environmentally friendly, we should be synthesizing this instead.
Yeah, okay.
But I just watched something on Netflix. So I think it was on Planet Earth 2 or something like that. So I'm on this environmental kick. But the lurbinectidine data are quite interesting in the second-line space. The response rate is quite nice at around 40% with a median PFS of 4 months, which is, beats out a lot of what we've seen, certainly immunotherapy. There is a randomized phase 3 trial called Atlantis that's going to combine this with doxorubicin. Different ways of taking action on DNA damage, basically. So I think there are still some compelling things that are out there, in addition to stuff that we haven't mentioned in the space with PARP inhibition and things like that. So even outside of immunotherapy, there's a lot of activity that I'm hopeful for.
Others, any thoughts?
We've seen our share of disappointments.
Yeah.
Rovapatuzumab, tesirine, affectionately called Rova-T, looked quite promising, at least initially, and ultimately in phase 2 trials, an expanded cohort, the response rate was less than 20%, and the trial was marked by severe toxicity with major fluid retention. I think there's still some Rova-T trials out there, and I share your feelings that we've got to crack the nut here. We've got to really figure out that some sort of immunotherapy, perhaps combination approach, might have a benefit. But the absence of a benefit in the maintenance setting for the Ipi-Nivo combination, which anecdotally I've given in relapsed patients, I've actually seen some phenomenal survivals. I have trouble reconciling all of this. And I suspect that when we're treating folks with extensive small cell and maintenance, we're fooling ourselves. They're not really maintenance. They're probably having a cult progression, and the drugs are just not working that well. So we need to do a better job of figuring out which combinations to use, and certainly figuring out that elusive biomarker that'll enable us to choose the proper patients for these trials. And frankly, most of the advances until atezolizumab with radiation. Concurrent chemoradiation as opposed to sequential, and PCI. That spelled the survival differences the prior 30 years.
Yeah, the two, well, in extensive stage disease, I think there are two controversial areas. Maybe one of them is not so controversial, and that's the role of PCI. There was an initial enthusiasm for it after the EORTC trial, but then the Japanese trial kind of quelled that a little bit. And then there is a remaining issue of, are there patients who have robust responses that may benefit from chest radiotherapy? The old Jeremic trial years ago.
Yeah,
your thoughts?
And there was another European study by Ben Slotman that did show 2-year survival benefit to thoracic radiation. It certainly, thoracic radiation was not delivered in Empower 133, so most of our patients are going to be getting carbotopicide and atezolizumab. Is thoracic radiation safe in that setting? It's unknown. NRG Oncology is designing a trial right now for extensive stage small cell that will incorporate thoracic radiation with immunotherapy, so there could be some continued advancements building on that backbone.
Are people excited about the possibility, based on the survival benefit we saw in Pacific, that the ongoing trial that I can't remember the name of in limited stage small cell will have similar outcome, or do we think?
Certainly
I think we have to be enthusiastic. We're oncologists, Mark. We're always optimistic. But
the glass is always half full,
exactly.
right?
And it's LU005.
Yeah.
What's that?
LU005.
05, is that the name? Okay. All right.
Yes.
And the status of that trial is?
So it activated on May 28th, 2019. So it is.
Oh, it just started.
It just activated. So
okay.
I think centers are starting to put it through their IRBs, and hopefully we can start putting.
Sadly,
patients on the
we're
trial.
still comparing 70 gray to 45 gray BID. I mean, that trial is just finishing.
Yeah, that trial's ending, and now LU005 is opening.
We are opening that trial.
Yes.
So we're working on it too.
But to
Yes.
Corey's point, into your credit, your credit of your field, I mean, all the advances, certainly in limited stage disease, have been at the hands of our radiation oncology colleagues, and so that's an integral part of treatment.
Absolutely.
Is there anything you're particularly excited about in limited stage disease from a radiation oncology point of view?
Well, our radiation technologies are always improving. Certainly, certainly IMRT techniques allow us to reduce radiation doses to the lungs and the heart. Image-guided radiation therapy, also routine use of 4D CT and radiation planning. Those are all really now standard of care and should be used when we're giving curative doses of thoracic radiation. I think that certainly proton radiation is being tested in RTOG 1308 for non-small cell lung cancer patients. At ASCO this year, we saw an interesting abstract looking at proton versus photon radiation in locally advanced solid tumors, different histologies, and there was actually a significant difference in acute high-grade toxicities. They were much lower with proton versus photon radiation, so that might be a home for that advanced technology going forward.
Great.